Well, thank you very much. It's a pleasure to be with you all again. As you've already heard, rumors of my retirement have been greatly exaggerated. It's been a great privilege for me, in fact, since 2007, which was the date, to have worked here in Newcastle. And it's been a privilege to work with Bill and Deb largely on the outflow tract and particularly on the aortic root. So I'd like to follow up what Deborah has just told you and show how we can translate that developmental knowledge directly into an understanding of the anatomy of the aortic root. You'll all recognize, I hope, the drawing by Rembrandt. The man you see in the middle demonstrating is Dr. Tulp. And as good an artist as Rembrandt was, in this picture, which is found in the Maurits house in Den Haag, he unfortunately has painted the right arm in the left arm's place. So we're going to try to do a little bit of that, and we're going to talk about the aortic root rather than the pulmonary root, although, as Deborah has told you, they're built from the same blocks. Much of what I'm going to share with you is dependent upon a collaboration I continue to have with this young, well, now relatively young, Japanese worker, cardiologist, Shumpei Mori. Shumpei came to visit me in London several years ago now and said he wanted to work in my laboratory. I explained to him that I didn't have a laboratory anymore, but we've been pen pals, and he's produced the most amazing work using virtual dissection of computerized tomographic data sets. And much of what I'm going to show you depends upon the work I've done with Shumpei. He's now, in fact, working in Los Angeles. He's working in the laboratory of Kalyanam Shivkumar, who runs the Arrhythmia Center in the University of California in Los Angeles. And together with Shiv, he's rehabilitating the McAlpine Atlas, which is an amazing piece of work produced in 1975. And the importance of all that was to put the heart back into the chest. And this is what Shumpei has been able to do using his computerized tomographic data sets. And for the larger part of my career, I ignored the basic rule of cardiac anatomy, which was that we should describe the heart as it's positioned within the chest. And had I had the material at the early part of my career that Shumpei has produced, it would have been so much easier to describe to all of you the way the heart sits within the chest. So you will all recognize that I'm showing you a chest radiograph, and Shumpei has taken the data set that came from this particular individual who was being assessed for coronary arterial disease, and he has segmented the different parts of the heart. So you see, we can now place back into the chest, as they lie during life, the esophagus, which you see in green, the trachea, the tracheobronchial arrangements, which you see in silver, and then Shumpei has shown you the location of the morphologically left atrium, which, as you all know, is the most posterior of the cardiac chambers. And then we can put in the left ventricle. And rather than going from top to bottom, it goes from front to back within the heart. Then, the focus of our attention during this session is the aortic root. And there beautifully you see the aortic root. You see its origination from the left ventricle. But when we put in the right ventricle, we see that the right ventricle wraps itself around the aortic root, with the tricuspid valve being the most inferior of the cardiac valves, the pulmonary valve being the most superior. And then we can complete the cardiac silhouette by putting in the right atrium. And then you see that rather than being right-sided, in reality, the right atrium, the right ventricle are anterior structures. And this is the way we should have been describing the heart throughout the time, but for reasons that escape me, but I went with them for quite some time. When we describe the heart, we take it out of the heart, we sit it on its apex, and we describe it in what we call the Valentine position. But now, with the availability to all of you of three-dimensional data sets, we really need to start putting the heart back into the chest, as you see here. So then, when we take the data sets, or rather when Shumpei takes the data sets, he can show you precisely the location of the aortic root. And you see its posterior part, that different leaflet that Deborah has just been emphasizing to you, is wedged between the aortic and mitral valves. And what we see very beautifully from this reconstruction is that the aortic root truly is the centerpiece of the heart. And if we understand the relationships of the aortic root, in reality, we understand the entirety of cardiac anatomy. And that will be our focus for the remaining of this morning. But if we're going to do that properly, we have to be able properly to describe what is making up the aortic root, to understand the location of those building blocks, if we're going to be able to relate what we see during life to what Deborah has told you. We now understand what happens during development. So as Keynes said, we have to escape from some of our old mantras. And there was a very important study done by the German cardiac surgeons quite some time ago now, and they sent a questionnaire to surgeons all around the world, and they truly showed that at the time, 2012, the way people described the aortic root was a Tower of Babel. And they made the plea at that time that we should try to rationalize the words we use to describe the root. And we've been trying to do that since, and I hope we've been making progress. So if I show you the location of the aortic root, you all probably see it much more frequently than I do, because every time you do a parasternal long axis section through the heart, you see the aortic root. And you know that being the centerpiece of the heart, it is interposed between the left atrium at the back, the subpulmonary infundibulum at the front, which is wrapping itself round as the right ventricle extends up to the pulmonary valve. And then when we look at the aortic root in this sectional approach, we see that the key to its understanding is the semilunar attachment of the valvar leaflets. And distally, the leaflets are attached at the sinutubular junction, and I emphasize it is sinutubular junction. You will all read in most of the literature the so-called sinotubular junction. It has nothing to do with China. It is the sinutubular junction. And then the part of the root that gives us the greatest problems in description, the virtual basal plane. And this is no more than a geometric construction that is made by joining together the nadirs of attachment of those semilunar leaflets. And I know that many of you in the room will continue to call this the annulus, the echocardiographic annulus, but there is nothing there. It is truly a virtual basal plane. So for me, as an anatomist, I can take out the aortic root, I can open it, and I can show you its component parts. And the essence of the Tower of Babel was to seek words that permitted us to distinguish between these components. And so now I like to talk about the sinus, which is made up of the arterial wall, and then supported from the sinus, we have the leaflets. And I don't use cusp at all, because again, if you go into the literature, you will find that cusp is often used interchangeably to describe either the sinus or the leaflet. And I firmly believe that if we're to describe the root properly, it is essential we distinguish between the leaflets and the sinuses, as I will show you eventually. We also then need to look at the area between the leaflets as they ascend up to the sinutubular junction. And this is the fibrous interleaflet triangle. We then need to look at the way that the leaflets are suspended within the sinus. And this is the work that Professor Schaefers and his colleagues have emphasized in their excellent works coming out of Hamburg. And they've described the effective height of the leaflets. And note that when they coapt, they do so barely halfway up the length of the sinus. And then they also recognize the geometric height of the leaflets. If we then look down on the aortic root with the valves in their closed position, we recognize the peripheral attachments of the leaflets at the sinutubular junction, the so-called commissure, but we also need to recognize the way that the leaflets come together as they extend to the centroid of the valvar orifice. And this is the zone of apposition between them. If we then open the root and we take away the leaflets, we can also see additional features of the root. I've opened it from behind, so we're looking at it from standing behind the heart, so you recognize the sinus giving rise to the left coronary artery, the sinus giving rise to the right coronary artery, and then the posterior of the sinuses, which we call the non-adjacent sinus, and in most instances, that non-adjacent sinus does not give rise to a coronary artery. On rare occasions, however, it may give rise to a coronary artery, and that is the problem with calling it the non-coronary sinus, because it's not always non-coronary, it is posterior, and it is non-adjacent to the pulmonary trunk. We see that at the base of the triangle that separates that sinus from the right coronary sinus, we see another crucial part of the heart, namely the membranous septum. And we can also see that that leaflet of that non-adjacent sinus is in fibrous continuity with the aortic leaflet of the mitral valve. And that is also important because at the base of the two sinuses giving rise to the coronary arteries, we find myocardium. And we can see that in the virtual dissections of Shumpai's computerized tomographic data sets. So again, we are standing behind the heart and we're looking forward. So you see the left atrial appendage, the left ventricle, and the infundibulum. And then if you look at the aortic root, very nicely now, you see the narrowing at the level of the sinutubular junction. You see the virtual basal plane. We join together the nadirs of attachment. And then Shumpai has colored in the myocardium found at the base of the two coronary sinuses. And that is the ventriculo-arterial junction. And the ventriculo-arterial junction does not coincide in the two coronary sinuses with that virtual basal plane. So now Shumpai has reconstructed the root as you see it from the front. There is the root. It has length as well as breadth. It is limited distally by the sinutubular junction, and it is limited proximally by the virtual basal ring. But then, when we put in the anatomic ventriculo-arterial junction, you see it diverges away from the virtual basal ring in relationship to the two sinuses giving rise to the coronary arteries. So we can now take the same data set and we can look down on the root from above. And now we see that the sinutubular junction is relatively circular. We see how myocardium is incorporated at the base of the two sinuses, giving rise to the coronary arteries. And there now we recognize the anatomic ventriculo-arterial junction. But look at the arrangement of the virtual basal plane, because it is not circular. It is ovoid. And this is key to the way you measure it. Because if echocardiographically you measure from nadir to nadir, then you never cut the full width of the aortic root, irrespective of which way or which nadirs you choose. To take the full width, we need to go from one commissure to the opposite nadir, but even then, if we look at the two dimensions, we see they are dissimilar. And that is why now it is much better to take these measurements using three-dimensional techniques. So here in the computed tomographic data set, we see very nicely the sinutubular junction. We see how much narrower is the virtual basal ring. The widest part, of course, the mid-sinusal diameter. And then over and above this, we can measure the geometric height of the leaflets and also their effective height. And then if we put back the root into the heart, we also see the location of those key interleaflet triangles. And it is the presence of those interleaflet triangles that now permit us to distinguish the phenotypic arrangement of abnormal valves. And this is where we come back to what Deborah has shown us, because now we can distinguish the true arrangement of so-called bicuspid valves. So here is a patient, again from Shumpei's data sets, who has a so-called bicuspid valve. There you see the left coronary sinus, but then the other half of the valve is made up of fusion of the right coronary sinus, the non-coronary sinus. And between the two, you see the line where they have come together, the so-called raphe. But using the virtual data set, we can show that the valve is truly trisinuate but bicuspid. Because there, looking at the conjoint sinus, we see that it's made up of the non and the right coronary sinuses, and now we see the vestigial interleaflet triangle. So when we focus on those interleaflet triangles, we can see the true makeup of these abnormal valves, and again, we can recognize the raphe. So we now know that in some instances, there is only one, or rather two, developed zones of apposition in the bicuspid valve, because the third zone of apposition has not opened up, leaving us a vestigial interleaflet triangle. So in that way, we can be precise when we describe the phenotypes of the so-called bicuspid valve. Because the majority of valves that you now see in patients with these arrangements are so-called bicuspid, but they are built on a trisinuate proforma. And you can have conjunction of the right and left sinuses, the commonest variant. You can have conjunction of the right and non-coronary sinuses. The rarest variant is conjunction of the left and non-coronary sinuses. And as far as I know, we still don't know why that is the case and why that one should be so rare. But then, as Deborah has told you, in some instances, one of the components of the valve fails to form totally. And we think that one is the one derived from the intercalated valve swelling. I've always called it a cushion, but I've now been told that's incorrect, so now I'm going to call it a valve swelling or a valve primordium. And in that instance, the bicuspid valve is also bisinuate. And then you all know that in many of the patients who present to you as critical aortic stenosis, the valves are unicuspid but trisinuate. And it is a mistake to think of these as being bicuspid, as is the case in one of the common classifications. We should also remember the relationship to the conduction axis, shown to us a very long time ago by Tawara in 1906. So here you see the relationship seemingly very close to the nadir of attachment of the right coronary leaflet. We now know it's not quite as close, and here is a very recent study I've done in collaboration with Damian Sanchez-Quintana from Badajoz in Spain. You see the extensive inferoseptal recess of the left ventricle. The right fibrous trigone is pierced by the conduction axis, and then the membranous septum interposes between the conduction axis and the aortic root. So there you see outlined the location of the left bundle branch, and it's not quite as close to the nadir of attachment as suggested by Tawara's initial drawing. So perhaps there's a little more freedom between the aortic root and the conduction axis than previously I had assumed. So what I hope I've shown you is that now, with the availability of all these three-dimensional data sets, you can see what is going on even better than I can show you when I have the heart in my hands. And hopefully that will continue to improve as things move forward. So hopefully that has given you an overview of the aortic root, which will now set the scene for the remainder of our discussions in this session. Thank you.
Thanks very much, Bob. That was wonderful. I think we have time just for one or two quick questions. I think just while the audience is maybe trying to think of a question. Alan McGee, can we get a mic to Alan McGee?
Bob, that was fantastic. From time to time, I'm asked to put a balloon across the aortic valve to try to make it better. And sometimes it works. What should I be measuring to guide me?
I'm not sure I can answer that. It's very difficult to say. You know as well as I do that you would like to split it along the zone of apposition between the leaflets, but that's exceedingly difficult. So I honestly don't know the answer to your question. Sorry, can't help you. You put it in and you do your best, and then you see what happens.
Great talk, brilliant as always. Just a brief comment regarding the bicuspid and bisinuate valve. I happen to see the occasional bicuspid valve, and essentially always I find a rudimentary commissure. So I wonder whether this truly symmetric and bisinuate bicuspid valve really exists, or whether it has not more the character of a yeti. Everybody speaks about it, nobody has seen one.
It's a very good point you make. I think that we did a study a long time ago now when Annalisa Angelini was with us in London in the mid-1980s with the late Michael Davis. And at that time, we gathered together 100 hearts that had so-called bicuspid valves. And in those hearts, when we examined them and we looked for the interleaflet triangles using the criterion I've suggested today, we were truly able to find cases there was no raphe, there was no interleaflet triangle, and to all intents and purposes, those hearts were bicuspid and bisinuate. I take your point that it could be very difficult to recognize those in the clinical setting, but I think that if we begin to look at them with the resolution that Shumpei has shown us is now possible, looking for those vestigial interleaflet triangles, I think that will be the way we find whether they do exist. They are, as you say, exceedingly rare. As I recall, in our series of 100, we had, I think, 3 or 4 that we felt were truly bisinuate and bicuspid. So I think it does exist. And as Deborah says, we now have the evidence from the mice that you can create these mice with truly bisinuate valves. She showed you one. So I do think it exists. How easy it is to diagnose them, that is something you will have to look for. But I think they truly do exist.